This presentation will cover Parkinson's disease. I'm Bethany Vonhoff, and I'll be your presenter today. Parkinson's disease is a complicated neurologic disease, and this presentation is just going to cover some of the basic understandings of what the disease is and how we treat it. The definitions associated with Parkinson's disease are really terms that are associated with movement disorders. These are terms and definitions that you would see pretty commonly in a patient's chart if they have Parkinson's disease. The hallmark symptoms of Parkinson's disease are movement disorders. So we think about bradykinesia, which is an abnormal slowness, rigidity, or difficulty initiating and terminating actions, and a masked facial expression. So basically, when you look at a patient, they don't seem to be showing any emotion through their facial expression. Another classic sign of Parkinson's disease is a tremor at rest that often goes away when a purposeful movement is initiated. Finally, the last definition here is akinesia, which is a loss or impairment of voluntary activity or movements. Parkinson's disease typically occurs in older people, with the typical age of onset being about 60 years old. However, you might be aware that there are some very famous examples of younger people getting Parkinson's disease, including Michael J. Fox, who was diagnosed in his 30s. Even though Parkinson's disease is relatively common, we don't entirely know what the cause or causes are, so you're always looking for possible ways to prevent it or to watch for particular populations that may be at higher risk. For example, certain rural populations seem to have a higher incidence, and there's speculation that it might be from contaminated well water from pesticides or fertilizers. Another thought is that it might be due to high exposure of heavy metals. In particular, aluminum has been a focus of researchers. There's some evidence showing that caffeine may be protective for patients in decreasing the prevalence of Parkinson's disease, but I'm not sure that the evidence is strong enough on its own to start drinking caffeine. Also, there was an observation that patients who smoked cigarettes rarely went on to have Parkinson's disease. Now, this was troubling because there are so many negative health consequences of cigarette smoking that we really don't want there to be a health benefit of smoking. But the hypothesis is that it's not the cigarette or the tobacco that's the protective factor. It's believed that patients who smoke cigarettes regularly and become addicted may have a lower predisposition for Parkinson's disease because they have a larger dopamine store. Dopamine is the neurotransmitter that runs out in Parkinson's disease. Dopamine is a very important neurotransmitter that reinforces pleasurable behavior that's associated with addictive behaviors. So the thought is that if you're someone who has a lot of dopamine stored and you smoke a cigarette, you're going to have a big surge of dopamine, and you're going to be more likely to find that experience pleasurable, and your brain is more likely to seek it out again. Someone who does not have the same dopamine storage may not be able to mount the same dopamine surge after a cigarette, and therefore it's not going to be as pleasurable, and maybe that makes it less likely for that person to want to do it again. So again, it's not the cigarette smoking that's being protective, but possibly that people with larger stores of dopamine are more likely to be addicted to cigarette smoking, and the extra dopamine is associated as a protective factor for Parkinson's disease. But lastly, because the pathogenesis of Parkinson's is unknown, there are probably a lot of unknown causes that we are unaware of at this point. This is a simple cartoon of the brain that shows you the area of the brain that is affected in Parkinson's disease, and that's the substantia nigra. You can see that circled on the right side. And you can see the dopamine pathway is central in this area of the brain. And this is the area of the brain that loses dopamine, or the amount of dopamine decreases over time. This is another cartoon showing a side-by-side comparison of a healthy or normal system versus a system that's affected by Parkinson's disease. What you can see on the left side of the healthy system is the substantia nigra has a good amount of dopamine, and the basal ganglia has a little bit of acetylcholine. This is the normal balance. On the right side, you see the Parkinson situation, in which there's a decreasing amount of dopamine in the substantia nigra and an increasing amount of acetylcholine in the basal ganglia. This balance is out of whack. What we try to do with drug therapy is to try and restore the balance of dopamine to acetylcholine. If you start to think about these competing issues with regard to the treatment strategy, it'll start to make a lot more sense. The substantia nigra is responsible for voluntary movement, and this is the area of the brain that loses the dopamine storage, and then the patient starts to lose voluntary control of movement. There's an acronym TRAP, which can help you remember some of the symptoms or clinical presentation of Parkinson's. There's tremor, which tends to go away when purposeful movement is started, rigidity or stiffness of muscles, akinesia, which again is the lack of movement or slow movement, and postural instability, problems with balance and gait. Another common one that doesn't quite fit the acronym is dystonia or lack of muscle tone. This slide shows a few pictures of an artist's rendering of how patients describe their Parkinson's symptoms. When patients talk about how it feels, you'll hear them saying things like, when I'm sitting in a chair, it feels like there are ropes keeping me in the chair and I can't initiate a movement. I can't get up. If you do a physical exam on a patient with Parkinson's, you can feel the rigidity and it almost feels like there's a cogwheel in the elbow. Also, we also talked about patients often have difficulty maintaining coordination and balance, and there's also a tremor at rest that tends to go away with purposeful movement. Patients with Parkinson's also have other symptoms related to a disturbance in the autonomic system. This can include things like orthostasis, sexual disturbances, and lack of bladder or bowel control. Some patients will go on to develop mental status changes and sleep disturbances. We will continue on now with treatment. And this picture is a reminder that the goal of treatment is to restore the balance between dopamine and acetylcholine. The substantia nigra needs more dopamine, and the basal ganglia needs less acetylcholine. The medications we have mostly target this balance. It's important to know that when we say we are treating Parkinson's disease, we are really treating the symptoms of the condition. We don't really know yet how to treat the underlying disease progression. So the agents we use are either trying to increase the amount of dopamine, so we may use dopamine agonists which act like dopamine, or we use agents that increase the endogenous dopamine circulating in the brain, and then there are a few other agents we'll talk about briefly that try and block the excess amounts of acetylcholine. The first agent is Mirapex or pramipexole, and it's a dopamine agonist. It binds to the dopamine receptors just like the endogenous natural dopamine would. You can see in this cartoon that when the Mirapex is bound, the receptor looks just like it does when the dopamine is bound. Because this agent is mimicking dopamine, it makes sense that the side effects with these agents are very similar to endogenous dopamine, and dopamine is known for causing some classic problems. The first is nausea, which is seen in about half of patients taking dopamine agonists. It's common for patients to vomit when they are given dopamine agonists, or an agent that helps maintain dopamine levels or limits its ability to be cleared from the body can also cause this nausea and vomiting. Another common side effect is orthostasis. Excessive amounts of dopamine can cause a fairly dramatic drop of blood pressure, so patients can faint, especially when going from a laying down to a standing position. This can be a particularly serious problem if the patient has underlying cardiac issues, because the body's natural response to a fast drop in blood pressure is for the heart to beat rapidly. So this can cause complications if the heart cannot stand this increased rapid effort. Because these agents work in the brain, you'll also see some CNS side effects. Often it's these CNS effects that are the dose-limiting side effects. In an upcoming lecture, we will talk about psychosis, and there's almost an inverse relationship between psychosis and Parkinson's. Parkinson's is too little dopamine, or not enough dopamine, and psychosis is too much dopamine. Unfortunately, we haven't figured out how to limit the extra dopamine only to the area of the brain that we need it, so the excess dopamine can spill over into other areas of the brain where it can cause the psychosis-like symptoms. This slide really just emphasizes the point that Parkinson's is not enough dopamine and psychosis is too much dopamine, and we don't know how to specifically target the area of the brain for either of those conditions. So in patients with Parkinson's disease, we can cause psychosis, and in patients with psychosis, when we try to block the excess dopamine, we can cause movement disorders. So that is an unfortunate relationship, but hopefully by seeing this relationship, it helps you understand the strategies we use to treat these conditions, as well as why we see certain adverse events with drug therapy. Because of the potential adverse events associated with dopamine agonists, there are certain patient populations that we are very careful with using these agents. As we've already sort of mentioned, we want to be careful with anyone who has a history or pre-existing psychiatric disorders, and also patients who have pre-existing cardiac disease because of the reflexive tachycardia that occurs following the drop in blood pressure. This doesn't mean that we would withhold treatment from these patient populations, but we would monitor them very carefully. Another agent that is used very commonly is levodopa, which is a precursor to endogenous dopamine. So this agent will cross the blood-brain barrier and will then be converted into dopamine in the brain and then act at its target sites in the CNS. We cannot give dopamine directly because dopamine does not cross the blood-brain barrier. The levodopa is also converted to dopamine in the periphery, which is where most of the adverse events come from. We typically do not give levodopa as a single agent by itself. We tend to give it in conjunction with another agent that tries to minimize the adverse events and limits the conversion of levodopa to dopamine in the periphery. Many of the side effects are the same side effects that we already talked about because of the conversion of levodopa to dopamine in the periphery. The enzyme responsible for converting levodopa to dopamine in the periphery is dopa decarboxylase. So the drug carbidopa is an inhibitor of this enzyme. By inhibiting the enzyme, you prevent the conversion of levodopa to dopamine in the periphery. This reduces the adverse events and increases the efficacy of levodopa because more of it can cross the blood-brain barrier and work at the target CNS site. This combination, carbidopa-levodopa, is known as Sinemet. Levodopa does have some specific patient instructions regarding administration. It does need to be given on an empty stomach to help increase absorption. Additionally, patients are encouraged to avoid high-protein diets, which can interfere with absorption. There can be a drug-drug interaction if these agents are given with MAOA inhibitors, or an increased risk of hypertensive crisis, and there's also an interaction if you give levodopa with traditional antipsychotics. If you think about it, the antipsychotics are trying to block the excess dopamine, and now you're giving an agent that is trying to make excess dopamine, so the two are really working against each other, and that just doesn't make a lot of sense. Selegiline is another agent that can be used to try and increase the amount of dopamine in the brain. This agent works by blocking a specific MAOB enzyme. This enzyme is responsible for breaking down dopamine. So by blocking this enzyme, dopamine is not metabolized or broken down as effectively, so there's more dopamine hanging around. Adverse events for selegiline include insomnia and jitteriness. However, we don't have to worry about the same tyramine effects that we would for an MAOA inhibitor. There are some reports that selegiline may have some neuroprotective effects, that it may prevent an accelerated decline in the patient's condition. There's also a second agent with the same mechanism of action, racegiline, but traditionally in the pharmacy, I see more selegiline than I do racegiline. Another agent that can be used in Parkinson's is Comtan, and it gets the name because the enzyme it inhibits is COMT, catechol O-methyltransferase. This enzyme is also responsible for the breakdown of levodopa, so by inhibiting this enzyme, we get more levodopa, so that hopefully the levodopa is able to cross the blood-brain barrier and be converted to dopamine in the CNS and work at the target sites. Comtan is only given in conjunction with carbidopa and levodopa. Some side effects for Comtan include liver toxicity, it can also change the color of your urine, and it can exacerbate orthostasis, and it can also have some of the same GI upset and dizziness that we already talked about, so it can exacerbate some of the same adverse events known for levodopa. The next line of therapy for a patient who may be building up some tolerance to dopamine agonists that we've been administering is to try and block the excess acetylcholine, and that agent that we use is called cogentin or benztropine. This agent is an anticholinergic agent, and it blocks the effects of the excess acetylcholine seen in the basal ganglia in Parkinson's patients. It's effective against the tremor and some of the dystonia seen in Parkinson's patients. Again, you can see some of the classic autonomic effects of anticholinergic agents, such as dried mouth, blurred vision, and sedation. Amantadine can also be used in Parkinson's disease. We don't entirely know how it works, but it's been used for a long time. It's also sometimes used to treat the extrapyramidal side effects of antipsychotics, which we will talk about in an upcoming presentation. The adverse events seen with this agent include very vivid dreams, dry mouth, and there's a unique side effect, which is livedo reticularis, which is a mottling of the skin. You should be very careful using this agent in anyone with renal impairment. In summary, what we're trying to do when we treat Parkinson's is to either boost the amount of dopamine in the substantia nigra or to block the excess acetylcholine in the basal ganglia. And we have several different agents that can help us with this balance.